Okay, so we are now uh, delving deeper and we're going into the examination of each cranial nerve. Or rather, there are times when you have to lump them all together or lump several cranial nerves together as you test them. There are advantages to that when you lump cranial nerves together, especially when you do reflexes. You test a lot of things in just one go. Um, of course, if you test one at a time, you also isolate the nerve. But again, it is very important that you understand the basic concepts first before you can understand testing. And once you know the normal response, then you can move on to the pathologic response. And this is where it gets interesting. Now, so let's begin. Um, okay. Now, for this session, we will just be taking up 1, 2, 3, 4, and 6. We'll limit it to that first because there's a lot of ground to cover. And even so, we will just be handling or we'll just be dealing with very superficial topics. Now, of course, you might need, if you really want, if you're really serious about your career, and if you're really curious about the physiologic process, one very interesting aspect here is your vision, the way you look at things, the way you perceive light and interpret the images in your brain. That is actually a very, very interesting topic. And actually, your Guyton, your physiology textbook, Guyton, offers a very comprehensive discussion on that. It's not very hard to understand, actually. But if you do take the time and review and go in deeper, that will give you, number one, um, a big advantage over others. And number two, it will give you an appreciation of how complicated you are made. So first, let's begin with cranial nerve number one. So cranial nerve number one is this one, your olfactory nerve. You can see that it is just at the base of your frontal cortex. Okay, this is the nearest to your brain. Actually, you have your nasal septum, nasal cartilage there. And if you hit somebody here really hard, that might drive it in here and you could kill them. But why am I saying that to you? I don't think they're gonna use that, but it's an interesting thing. Um, Egyptians would usually stick a wire up there, break the break this bone, and sort of drain the brain from there. If they're making mummies, they want to take out the brain because that's the one that rots very fast. So they take out the brain using that through your nose. Now, um, after saying that, um, how do you test your olfactory nerve? Very simple and not so simple. It is smell. Okay, so what you're after here are the chemoreceptors. Okay, the ones that detect certain chemicals. So what you need are aromatics. Very important because there are also some substances that don't they do have smell, but they're more like irritants. Okay, very strong, let's say alcohol. Okay, your body might perceive the presence of alcohol not so much as the scent of alcohol, but the way it irritates your cells there. So what you don't want is to stimulate the nociceptors. Okay, you don't want that. You want chemoreceptor. So aromatics, coffee, okay, is good. Ammonia, sometimes you can get ammonia pads, okay. Mild perfumes, okay, so you can test that, and you can block off one nostril and test it, and vice versa. Now, well, you could also bottle fart, but it probably won't last long. Nobody has tried that. You could. Would be probably fun. But anyway, that's how you test your olfactory nerve. Just remember though, um, your sense of smell and your sense of taste are very much related or linked to each other. And sometimes just giving the patient some idea would already sort of change the way they perceive. Like telling them, oh, I'm going to open a bottle of perfume. So they're already expecting some nice aromatic scent. So trying to avoid that. Okay, so let's go to the next. Let's go to your vision. Now, your vision is actually very, very complicated. So much so that your Guyton physiology has devoted several chapters just on vision alone. So if we look at your eye, not a very good drawing of the eye, but if you really look at your eye, the main receptors there would be your, what do you call this, at the back of your eyeball. This is what you call your retina. They are photoreceptors. Okay? Photoreceptors meaning they are stimulated by light. There are two kinds. There are cones and there are rods. Cones see color. Okay. Rods is black and white. Now, in that retina, that's a wide piece of hyper hypersensitive receptors, millions and millions and millions of receptors there. There's actually one part that is even where it's really really packed with cones. Okay, and that is what you call your fovea centralis. Okay, that's your most, that's the area of your retina where most of the cones are situated, and that is the area of sharpest vision. If you look at something or someone and you want to take in all the details, your eyeballs will focus, will try to put the image right into the, okay, so if this is a person, forgive me for that drawing, but it wants your eyeballs position themselves in such a way that the image falls into your fovea. Okay. Now, if you also notice when you're out at night, it's dark, so you don't really see color, just muted grayscale tones. So it's your rods. That's your night vision, and you have rods spread out along your retina, except for your fovea. So it is said that if you want to see something in the dark, don't look at it directly. You point your eyes to something else, and then you try to observe that something, maybe it's an aswang, in your peripheral vision. So that's how you do it. Now, there are many ways where you could test your cranial nerve too, your optic. Number one is visual acuity. How well does your retina, especially your fovea, can distinguish light and details. Okay, so the most standardized test there is your Snellen chart. Okay, most of you are familiar with this. When you go to an eye doctor or an optician, you would see this chart, and there's actually a particular distance. Okay, there's a distance there, and you try to read these letters, and they become smaller and smaller. And of course, you look at this guy. This guy looks at the picture first with both eyes, and then later on, to just to make sure, or just to isolate it, you cover one eye, read, and then you cover the other eye. Okay, so that's how you do it. There are Can you bring this in your in your kit, in your examination kit? Yes, there are those that are just pocket size, and you have to read because there's a particular distance where you have to put that. Okay, so that's for visual acuity. Now remember, guys, we are just running through these. um, there are still a lot of nitty-gritty details when you're checking for visual acuity, but this will suffice for now. Okay, visual field. Okay, no, this guy did not poke his eye. Okay, visual field defect or visual field examination is physiologically, you have in your retina a certain blind spot, and you're checking all parts of your retina if they're working okay. Now, what you do here is you let the patient look straight. The patient has to understand that he has to look straight at a particular object and do not move the eyeballs while you are moving. Look at this guy. Look at where his fingers are. Okay, so you check one eye after the other, and you check if there are areas that are blind spots. There Sometimes you move you when you move your finger far enough, the retina could not cover it anymore, and that's how you record it here. First one eye, then the next. Now, of course, there's a more sophisticated way of doing it. It's a bit expensive, but it's it's fast, and it gives you this readout in a short while. There are advantages and disadvantages to that. You could standardize it. It's very easy for the tester. But then again, if this machine breaks down, you're still left with doing that. And it is sometimes important that you know how to do it without machines, because once everything breaks down, you are still left with what you know between your ears. Now, so why do we need to check for your visual fields? Okay, you might be familiar with this, but this is your optic tract. You can see that your optic nerve goes in the front, and it has your optic chiasm where it sort of merges fibers together and goes on their separate opposite way. And if you cut them, if you cut them, I mean, at different levels, it will give you different um, visual field defects. Okay, so once you've mapped it out, you might say, oh, this patient has bitemporal hemianopia. Okay, why do they say bitemporal? Just remember this. Um, Look at this retina. Okay, this retina here, look at the screen there, actually looks this way. So basically, this is what you call your nasal field. And this retina over here actually takes in images from this side. This is your temporal. Okay? Temporal, nasal. Okay? So, when you say bitemporal, like this, binasal, okay, you're blind here. Okay? When you say homonymous, you're blind here, you're blind here. Okay? Like that. Here, here. Okay. It might sound too much, but if you just pause, think about it a little bit, read a little, it's worth knowing because it's very, very fascinating. Okay, third is your, now my head is blocking it, fundoscopy. Okay, fundoscopy is when you get an ophthalmoscope and then you look directly into the eye and you're actually looking at the retina. Your retina looks like this in your fundoscope. This one here, that's your optic nerve. Okay, and those are your vessels there. So by looking at it, you might find out, of course, it takes a lot of practice. Sometimes you would see that the optic nerve is atrophied. Sometimes you would see large tortuous blood vessels there, or edema, that's called your papilledema, okay, indicative of increased pressure there. So those are the things that you use to check the optic nerve directly. This fundoscopy is a bit difficult. Now, first the patient has to look straight, and then you have to look at into the pupils, straight into the retina. Okay, sometimes eye doctors would put in eye drops that will make your pupils bigger so it would be easier for them. But anyway, it's not simple, but with practice, it's not hard. Okay, now we're done with one, we're done with two. Let's now go to your oculomotor system, or some would call it optomotor. Um, well, there's a point there because you might get um, confused because one cranial nerve, that's three, is also called oculomotor. Now let's go, this time we are going to examine or to test the muscles in your eyeball. Now, your eyeball and the muscles of your eyeball is immensely complicated, so mechanically wonderful. Okay, imagine just looking at the screen, following the words, or following a certain object, a butterfly land from flower to flower. That takes a lot of um, engineering for your eyeballs. Imagine using you have two cameras and you focus on something that flies. Okay, and those motors are very precise, and that they are they don't get tired very fast. Okay, so if you just look at how your the eyeball itself is very intricate already. The muscles around it and inside is also another marvel in itself. It is very difficult for us to follow this or to replicate this on our own. Now, so we're talking about peripheral oculomotor system. We're just talking about the cranial nerve, the nerve, and the muscle. Okay? There's also what you call your central, and that's already your brain coordinating the movements of your eyes. Okay, because if you look into somebody's eyes, if you look close enough, you would see that the eyes are not actually still. They have saccadic movements. When you say saccadic, saccades, they don't move slowly like that. They sort of twitch. Okay, just like birds. Okay, the bird's head. Okay, they twitch. Now let's simplify everything for now, and let's just talk about the peripheral oculomotor system. And we're just talking about cranial nerve 3, 4, and 6. We want to lump them all together because, well, just to simplify things. And of course, they all work together anyway. Now, um, we're going to talk about intraocular, or actually, we're just going to breeze through this, and we're going to focus on your extraocular muscles. Okay? When you say intraocular muscles, it's the muscles inside this eyeball here. And what are those? Just to give you an example, one is your pupillary muscles. Okay, you have two types there. You have radial. Okay, they're arranged like this. Sorry, this is your circular, and then your radial are like spokes in a wheel, like that. So if you want to constrict the pupils, your circular muscles are the one contracting. If you want to dilate, your radial muscles are the one that's contracting. Another one would be, of course, let's go back. Well, you cannot make your pupils constrict and dilate. They're involuntary. Just like this one. There's another one. You have your lens. Okay. And then you have muscles there. So if you're looking at something close, like your tablet or your phone, you want your body. Okay, normally your lens looks like that. If you want to look at something that's near, your muscles will pull it flat, so it will become like this. Okay, you want your lens to be flatter if you want to look at something that's near. Now, if you want to look at something far away, your muscles relax, and so your lens becomes fat again. Now, this is why they tell you, if your eyes are tired, look at objects far away, because your muscles in the lens relax to get to take in those images. Okay, now I'll give you these lists. These are your muscles in the eyelids. There are intraocular, there's extraocular, and there's involuntary. Okay, these are involuntary muscles, and you have your voluntary muscles. Now, it is easy to remember their innervation just by remembering the exceptions. Okay, so remember these words: LR6 or SO4, LR6, sulfate, and whatever LR6 is. Just remember that. So SO, superior oblique, this is cranial nerve 4. LR6, lateral rectus, cranial nerve 6. Okay? All the rest is cranial nerve, um, cranial nerve 3. Okay? Now remember this also, your levator palpebrae. This is for your eyelid. Okay? So your cranial nerve 3 is also part of, or partly controls your eyelid. In what way? like that. Just remember, your 3 is like a pillar propping up your eyes. So if you open your eyes, if you open your eyelids, that's cranial nerve 3. What closes your eyelid? Remember your hook? Cranial nerve 7. Closes your eyelid. So if you cannot open your eyelid, cranial nerve 3 is your problem. Okay, so let's go to your extraocular muscles. So let's draw 2 eyeballs. Okay. Now, and I think after this will end, and then we'll have another session for reflexes because we're taking a bit of time already. Now, you have 2 eyeballs, the left and the right. Okay. Again, this is the time when you need to know how to draw. And fortunately, it's easy to draw. And once you know how to draw, it is it serves as a very good, simple guide in answering about extraocular muscles. Now, first, you need to draw 2 arrows like this, and then an arrow moving out. Okay, so the muscles that make the eyeballs turn out is your lateral rectus. Okay, lateral rectus. The one that makes your eyeball move in is your medial rectus, left and right. Okay, now another arrow up and down, up and down. Okay, medially, and then there's another one here, up, down, up, down. Okay, so the medial one is called your superior rectus. One here is inferior rectus. Okay, and the rest is now your obliques. Now, when you say oblique, try to reverse everything because the one that moves the eyeball up and out, something like this, it's more like this, okay, is your inferior oblique. The one that moves your eyeball down and out is your superior oblique. Always remember this, oblique is out. Okay, so inferior oblique, superior oblique. Now, once you've drawn this, it is already very easy for you to tell which muscle is working and which is not. So, for example, you want to look down. Okay, you want to look down. What muscles need to contract for your eyeballs to look down? Both eyeballs. So here, superior oblique and internal or inferior rectus. Okay, they would pull it down. Your eyeballs will look down. Okay, why will it not move from side to side? Because your lateral and your medial recti muscles are stabilizing it. Okay, so if you want to look down, that's your, okay, inferior rectus and superior oblique. Number 2, what if you look like that? You want your eyeball to turn to the down and left. Okay, down and left. So what muscles are working? On the left side, you have your lateral rectus, superior oblique, and inferior rectus. Those are the muscles that work. How about on the right side? It's going to be medial rectus, inferior rectus, and nope, not superior oblique, because it's going to look opposite. Okay, do you get it? So very important in drawing this is very important. How about number 3? Okay, you look up and to the right like that. So what muscles are working? Okay, on your left, you would have medial rectus, superior rectus. On your right, what's working? Inferior oblique, could be superior rectus, lateral rectus. Okay, so it's very easy if you have your um, diagram. Okay, so we will end here, and we're going to go to your reflexes next time. Okay, so thank you. I think we'll have a short exercise after this. Just check the Facebook page. So thank you.